Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to go back into the work that I said I would do with respect to anatomical variance or variance between anatomical resources. So first, what I need to note is that the manner in which I found the resources was a Google search. So on Google, type in the name of a muscle, and within the first 3 pages, looking for consistent resources. So consistent resources, things such as Wikipedia, Anatomy Zone, KenHub, Physiopedia. What's another one? There's like IMAIOS. There's also one that is exceptionally similar, but it's mildly different. I don't remember the proper name of it off the top of my head. Then there is Radiopedia. I think that's all of the ones. And then there's one that's like anatomy.app. The reason I use those is because they are the same ones that were utilized for the arterial supply. The difference with respect to looking for arterial supply versus neural supply or motor nerve is simply that more resources present the neural supply, the motor nerves. So if we look at the average number of resources that were available for the motor nerves, so how many for any given muscle on average that were found was 7.5 more or less. And I'm just going to lean towards the camera because I got to grab something and click. So please excuse that if you are watching. The average number of total resources for arterial supply was 5.7, right? So you see, so when I say there are generally more anatomical resources easily available through a simple Google search within the first 3 pages, within the resources already noted, there is more consistently representation of motor nerve to a given skeletal muscle. So 7.5 versus 5.7, I think, if I said that right. Now, because motor nerves will have varied descriptions, there ends up being more categories to try to describe what's the same and what's different. When you have more categories available, you would expect that each of those categories could easily have less within it or represent because you're fractionating the descriptions of the motor nerves to a given skeletal muscle more. You're giving more opportunities for fractionation or breaking apart into finer detail, aka more sensitivity. So you would suspect that what would be represented in any one would be smaller, right? Now, maybe that's the case, maybe that isn't. The important one for comparison. So I'll tell you the categories. There's the total number of resources. There is a category that is no levels, right? So there are going to be some areas where no levels of nerves are going to be noted, aka no vertebral levels. So areas where the motor nerve is from a cranial nerve. So there's no vertebral level for that, right? It's not going to be noted. It is not standard to note it. You could call them all C0, right? But really not. So it's a little dicey there. The variation from those categories is contained within the other ones, right? So for the ones that are really just cranial nerves, they won't be represented in those categories. For the ones where there is a mixture of a cervical nerve or something in the cervical region and a cranial nerve, they will be represented at least in some cases by the ones where there's no level. Everything else where a vertebral level would be important to indicate or common to indicate, then what we're looking at is how many have no level and are the same as the other ones, or like a group that agglomerates and sticks together, and then how many that do not report levels and are different, right? So these ones will also note variance from other reports, right? So this is kind of like a double dip in a bucket of different, right? Because where you could note vertebral level or where it would be common to note vertebral level, they don't. Right? So they're different, and I'm trying to be able to represent how often they're different than one another. Then we have same A, same B, same C, so 3 categories of same. a category for minor variance. So it's like it's pretty much the same, but it's different enough that if people who were not exceptionally familiar with some of the strange naming conventions and variants in resources, that they might not catch it. Then there's like just different, okay? So the prediction I made in the previous video when I talked about arterial supplies, that when we get to motor nerves, we should see less difference, right? So the category for different in the arterial supply, I think, was about 48%. Was that it? I'm going to click back over, so please excuse my head disappearing. Yeah, it's 48%. So 48% of the time, the descriptions of arterial supply were just different, right? Where I predicted that that would be lower. The average percentage where neurological descriptions or descriptions of motor nerves to the same skeletal muscles is different is 15.8% of the time. So that is smaller, right? That is notably smaller, importantly smaller. What you do get is groupings though, right? So you kind of get the same A, the same B, and the same C, right? So the average percentage where these descriptions of motor nerves are the same is we'll call it 35.7% of the time. Whereas with arterial supply, the average where it's the same is 40.15%. So the mirrored or explicitly exactly the same descriptions of motor nerves is technically smaller than that for arterial supply. So there's more that are just different for arterial supply, less that are just different for motor supply, but there's also less that are the same for motor supply. So you get 35.7% as kind of the dominant group, or the one where it's going to represent the bulk of the same description. Then you get the second category, which we call same B, or I call same B, is 6.5% of the time. Then you get another very, very rare thing where there's another third grouping that does note vertebral levels where applicable, where appropriate. And that's like 1.2% of the time. So that's kind of a nothing deal. But what it shows you is that they're going to be similar to one another, but there's categories where you get these clumps of the same description, but they're not the same as the other description. They might be somewhat similar. Then we also get the minor variance, right? So the minor variance is what's interesting. That's 5%, 24.52%. If you bring the minor variance could live with difference, or it could live with the kind of the same like big category. So that could either bump the 35 up to 35 plus 25. 35 plus 20 is 55. So like that could be 60% of the time where you could sort of suggest maybe it's the same if you wanted to slice it that way. It doesn't necessarily fit that way. But if you slap it over to the average difference, or that minor variation, it's not the same, it's not that different, but it's different enough that it is, sorry for stumbling, it's different enough that it could throw people off who weren't exceptionally familiar with these things and didn't accept that the variance was common. So let's just say you were testing people. The minor variance would probably screw people up, or maybe they'd be okay with it. So if you slap that over on the 15%, you get about 40%, so 40.35%. So this is a little bit more fine-grained slicing things apart. The thing to note that has the other category, so this is a category of difference where there's no levels, so it might say the right nerve, but it won't tell you the levels. So when you're getting tested or asked to talk about the spinal cord levels of of motor nerves, you want the vertebral levels so that the reporting is fully understood, right? So you try to name the whole path. It's about 16% of the time, so 16.3% of the time, there's no levels noted where you would want levels noted. To break that down, there is 9% of the time, so 9.5% of the time, there is a clump that is the same with no levels, and then about 6.8% of the time, so you could say 7-ish% of the time, there's a difference. So you kind of get that, yeah, what is it? 16.3, so yeah, like 9.5 and then 6.8% of the time where they're different, right? So we've got another category of difference. So there's this other like 16% that's different again, no levels. So if you add the 16, call 16.8 and 15, or sorry, 16.3 and 15.8, you just kind of call that 16 and 16. 32% of the time now you have this category where it's like different. So there is more variance in motor nerves in these smaller ways than there is with respect to arterial supply. Arterial supply, 40% of the time is just different, right? So there's different ways you can try to piece these categories together and try to make meaning out of them. So I'm sort of doing that, but I also would prefer to just note them as different categories, right? Because they're different because they are the same as one another. So there's a grouping that is the same as itself, but then it is different than all other groups. So that smaller variance is important because it could throw people off. One of the points of this work, one of the reasons that I'm doing this and reporting it, is I was being asked questions about specific answers to anatomical questions, where one of the things I've consistently noted across time, especially to students, is that anatomical variances or anatomical resources are different than one another. They will report things differently. One of the reasons is because the specimens studied to make the report are different. Another reason, sometimes there's just copying errors and there's style things. When looking through these reports on, or these resources rather, on motor nerves, sometimes there's just a style difference. Like the way that somebody writes it is different than the way somebody else writes it. So there's still these personal flair things and writing style that could impact how somebody would then learn anatomy and be able to comfortably regurgitate it or report it. Maybe that's a better term. The other thing is, if you are looking at any form of testing process, you need to make a lot of choices. You need to make a choice as to what is important. Is accuracy important? If accuracy is important, then if you allow people to utilize different anatomical resources, it will be unfair because you have to make a choice as to what is accurate as opposed to the range. You could choose to allow a range of responses, like a free text range, whereby, you could say femoral nerve L2, L4, you could say femoral nerve with no vertebral levels, you could say femoral nerve L3, L4, you could say, L2, L3, and then you could mark those all correct, right? The challenge would be, if you do it that way, there may be an instance where there's a judgment made that it doesn't fall within appropriate variance, but somebody could challenge it, right? So there's an issue of fairness. If you want to make something fair, then something like a multiple choice test actually has a benefit because it's a stable answer that everybody has the choice to choose between. They don't have to bring it from memory de novo or from scratch. I mean, from memory isn't really from scratch, but they don't kind of have to pull it out and report it accurately. It's already there, and they just have to choose between them, and their choice is indicative of their understanding of the resource that the question is pinned to. So if you have a multiple choice test, you have to have one resource that it's pinned to so that everybody has the chance to learn from that resource and then answer accurately in relation to that resource, right? So to make something more fair, you have to have one resource. You have to boil it down. The problem with anatomy is it is variable. So if you boil it down to a single resource, whatever errors are contained within that resource, or whatever differences in that between that resource and the human being that you're interacting with, will then be an opportunity for the error to be transmitted from the book to the person. Maybe there's a better way to say that. So let's just say you are a surgeon and you need to perform a surgery on the femoral nerve for some reason, whether say the roots, right? The roots of the femoral nerve. it wouldn't really work that way because you'd have imaging, so you'd know where the heck the issues were. But let's just say you have to trace the femoral nerve back, and you know the femoral nerve as being L2 to L4, so that's motor to the general anterior compartment of the thigh. So there's a problem with the anterior compartment of the thigh, so you immediately think L2, L4. Well, what if this person's a little bit different? What if their spinal cord is mildly shorter? No, it wouldn't even do that. But this person's different. They're L1, L3. Right? So you'd get the L2, L3 correct, but you'd mess up on the L1. It's obviously a hypothetical situation because surgery would be performed with things like imaging and the opportunity to actually physically trace the nerve should it be required. So you could do things like that. You could be accurate to the circumstance as opposed to just rely on the book knowledge. But it's an attempt to say that if the book is stabilized as a specific thing and your patient is different, and if you think the book is accurate, you could miss it in your patient, is the thing I'm trying to say. So you'd have to stabilize that knowledge against a single resource in order for fair testing, but the actual use of healthcare skills is between a practitioner and a human being who is approaching them for their skill set to solve whatever problem they're attempting to solve. So anatomy can be shown to be variable in resources as well as between people. Therefore, paper testing of anatomy is probably far less applicable to healthcare than people who are less aware of the variance would hope. So regulators or people who want to set bars of performance, maybe it's possible that they're less aware of that variance, so they can place value in anatomical paper testing or knowledge testing against a standardized resource as more valuable than it may be. Because when you're actually interacting with a human being, you still have to problem solve regardless of what the anatomy should be. So anatomy's often more physiology too. Anatomy you could argue that it's much more descriptive than it is predictive in its description. It's a really great starting point, but it's not as accurate as you would want it to be able to solve a problem just by thinking about it. You can't just think about anatomy and solve a movement problem for the person in front of you. You need to assess and test. So you need to assess and find out where the restriction is. You then need to test how they respond to interventions to find the most appropriate intervention, apply that, and then retest. So even though you can know large amounts of anatomy, the variance between the resources means it becomes hard to actually generate an appropriate testing process that accurately reflects the variance in resources. You have to choose one resource, or you have to choose to allow a wide variety of answers, and then you're not really rewarding people for accurate recall of information. Right? So now you have to change how you're testing things. You could also simply argue that paper tests of anatomy or knowledge tests of anatomy are not reflective of healthcare practice. Right? So I speak about this partially to have visible, identifiable record of concerns as people continue to talk about the regulatory process for osteopathy across the world. I will note what I believe I have noted before, that there is a drive to import things fully formed from other areas into osteopathy. So I talked about the patient-reported outcome measures, the things like educational concepts, things like competencies. So, well, they're doing it this way over there, we'll just do it this way over here. No, you have to build your competencies from scratch. The National Board of Osteopathic Medical Examiners, I've talked about their competency document before. They have definitely pinned it to easily available resources that people can agree upon as standardized. I happen to have disagreements with some of the things or the assumptions within those competencies, but if you're trying to develop a competency that is fair to test, I think they did a great job. But I have disagreements with what those competencies are and how they were built, so that's a different story. The variance that is easy to find between anatomical resources and between human beings and how their anatomy is organized is an opportunity to note these phenomena that you have to be really careful how you choose to test things to prove that somebody can do what you say they can do, that somebody knows what you say they can know, that the thing that you tested them on is accurately representative of the skill that they require to do their job. I have some minor challenges with paper testing of anatomy being properly indicative or predictive that somebody's going to be able to do hands-on osteopathy. Hands-on osteopathy is much more predicted, or I would argue it would be much more predicted in positive outcome performance by the ability to identify motion restrictions, whether on a macro level or a soft tissue yield pressure, on a willingness to test between hands-on approaches to see which one or ones the individual in front of you responds best to, and the ability to observably show change in movement characteristic after intervention. The anatomical knowledge that can be tested on paper would really help cognitively figure out what not to do, as well as how to instruct somebody to ask for further diagnostic from a professional who's not a hands-on manual osteopath, who can do things like order radiological studies. So anatomy matters. You should know anatomy. I just think the way that it is being tested has axiological or value-based judgments that may not accurately relate to how osteopathy is done, at least in the way it's being currently tested, or with somebody suggesting that it has a level of value to predict performance that it may not have. Right? So hopefully some of that made sense. Obviously, at times I will run away with words and get a little fast. So thank you for listening this far. Hopefully you've learned something, and we'll talk again soon.